So we move on to point 7, and this is a point that's very seldom reported or taught to medical students or dietitians. And it's the report from the MR-FIT trial, which was one of the largest trials ever of reversal or changing coronary risk factors to see what the outcomes were. And of course, the reasons we aren't talked about it is because it didn't work. So MR-FIT proves that reversal of all the major coronary risk factors, and I put the risk factors in inverted commas, because we just assume that they're risk factors. We're told that so often, we don't question, including the use of a low-fat diet, has no impact on longevity or mortality. So MR-FIT stands for Multiple Risk Factor Intervention Trial, and this was the protocol that was followed. 360,000 middle-aged men were screened for cholesterol and other risk factors, smoking, hypertension, and so on. And the 12,000 with the highest risk factors were selected. So this was the sickest of the sick. There couldn't be any more ill people, potentially ill people, than were included in this trial. And half of them were put on a prudent diet. They reduced their cholesterol, saturated fat, and total calorie intake, and they ate more vegetables and polyunsaturated fat, whereas the control group just ate their usual diet. And the effect of this trial was remarkable, and I didn't realize how effective the intervention was in terms of changing risk factors. So this is Thomas Moore's book, is one of the 3 that I always prescribe to people. The other 2, of course, are Nina Teicholz's book and Gary Taubes' book. But this was the original book, which looked at the early studies trying to link diet to heart disease and showing that there just was no evidence at all. So he describes how the results of this dietary intervention were extraordinary. Subjects reduced their cholesterol intakes by 42%, saturated fat intakes by 28%, and total calorie consumption by 21%. These outcomes have not been matched by any subsequent intervention. So if you wanted a real dietary intervention that worked, this was it. Using every technique then available, including monetary rewards, marathon group sessions lasting 2 to 3 days, during which subjects attempted to avoid smoking. Also the use of hypnosis and aversion therapy supported by continual monitoring by the interventionist, the number of smokers in the intervention group fell by 50%. And then there were remarkable changes in abnormal blood pressures. 87% of hypertensive subjects reduced their blood pressures to below the threshold defining moderate hypertension, and 67% reducing their blood pressures to the normal range. So there's no trial that could have produced better outcomes in terms of reducing coronary risk factors. So you would imagine that this must have a huge effect on subsequent incidence of heart disease and mortality. So let's see what happened. Blood cholesterol concentrations fell in both groups because the control group also were rather good at lowering their cholesterol. They reduced their smoking, and their hypertension was also quite well reduced in the control diet. After 7 years, 265 died in the treatment group. So clearly they're going to have to be more in the intervention group, but there weren't. There were 260 died in the control group. And the major conclusion from this study was that the cessation of smoking was the only intervention that influenced the outcome. So the conclusion of this multi-billion-dollar study was it's a good idea to stop smoking. And the other risk factors didn't seem to have any impact on subsequent risk. Now, it's obvious that lowering blood pressure, particularly if you don't use medication, must reduce risk. And the same with smoking, it must reduce risk. So the question is, well, did something else that the group did harm them? Was it the dietary change that harmed them and prevented any benefit from being shown by the reduction in smoking and the reduction in hypertension? When I look through the data, it's really interesting that to show that the cholesterol values in this study, we'll come back to that, they didn't really show much increase in risk. So in other words, if you look at this, these are the highest values compared to the lowest values. You'd say, gosh, well, that's quite a big increase in risk from say 15 up to about 40 units. But then you look at the units and it's per 10,000. And that's so that this is a minuscule increase in risk, which we'll come back to. But what does increase risk is having diabetes. That's clearly what makes a difference. And so if you have a high cholesterol and you have diabetes, then your risk is about threefold greater. Whereas if you don't have diabetes, raising cholesterol increases your risk, let's say twofold. But you must remember that the risk is low, so doubling of risk is small. So even trebling risk is quite small. Nevertheless, it's very clear that diabetes produces more risk in this trial than does an elevated cholesterol concentration. Now, these data were published by Stamler and Cannell, and Stamler and Cannell were both involved in the Framingham study, and they inherited the MRFIT trial as well, and they were very strongly committed to cholesterol being the major risk factor for heart disease. So when they looked at the MRFIT data, they produced this graph which suggests that risk rises and CHD deaths also rise. Total deaths increase and CHD deaths also increase with increasing cholesterol concentrations. The only problem was that they used unequal interval scales. So here they lumped everyone below 182. This group had a range of about 20 milligrams per 100 ml. This was also about 20. This was also about 20. But here there was an unequal distribution because this included many people with very high values. But what was of much more interest was the data was subsequently reanalyzed, and people questioned what's going on at the low level of cholesterol. And ESO published this data in the New England Journal of Medicine 3 years later. And ESO was independent. He hadn't been involved in the other trials. He hadn't been involved in the Framingham study. And see what he noticed. He noticed that total deaths actually rose at low cholesterol. So Stamler and Cannell had collapsed these data into this point here, and so they had avoided the identification that low cholesterol was as dangerous and as high cholesterol in this group. And the same for CHD deaths, actually, there was no difference. That didn't seem to make a difference. So at low cholesterol, there was clear evidence that total deaths were increased, but Stamler and Cannell chose to hide that fact. The next person who used this information was Scott Grundy, who was one of the first people to start promoting statin use. And so he was very biased towards the idea that cholesterol levels are important. So he published this important and influential paper in 1986, and it's essentially the same data. Here's the mortality rate, and it seems to be going up very, very steeply. And then he looked at the CHD risk, and you'll see here the risk for a high cholesterol is fourfold a low cholesterol. So that was the message that was spread around the world, that an elevated cholesterol risk increases your risk fourfold. But the question is, well, what does that really mean? Because again, no one noticed that this is per 1,000 patients. And so the annual death rate for people with a low cholesterol was 0.25%, and for a high cholesterol was 1.35%. So this fourfold increase really was of no particular consequence to anyone with the high or low cholesterol. For the simple reason that even if you increase risk fourfold, from a low risk it went up to a slightly less of a low risk. But Grundy used this information to startle the world, and which was very convenient because in 1986 was just before the statin drugs were about to be released. And so this paper caused the population to begin to believe that it was very important that you should lower blood cholesterol concentrations. So there's the risk fourfold. And then what he next did was to draw the same graph as he has the coronary heart disease risk on the right side. And there it goes, as he's indicated, goes from naught risk if your cholesterol is low, which of course is wrong because that may be coronary heart disease, but all-cause mortality is going up at this end. But he conveniently ignored all-cause mortality, as they tend to do. And so he said here, when you are with a cholesterol of 7.76 millimoles per liter or 300 milligrams per deciliter, guess what? 100% of your coronary artery surface area has atherosclerosis. So that's the graph. There you go. From these data of cholesterol levels and a small increase in risk, he says the problem is as your cholesterol goes up, your coronary atherosclerosis goes up. And so that once your cholesterol is 300, you got 100% atherosclerosis, which is nonsensical. That's never been shown. But again, this is what was allowed to be spoken about and promoted in the 1980s because of the fear of cholesterol and the knowledge that statins were about just around the corner.